development and recent advances on the technology of ESD using the specific products. Okay.
Chi tiết này là đầu dò phải không?
So these are my topics today.
Tiết
So
tên
first topic is
BBS.
gastric cancer after H. pylori infection. As you know, the H. pylori infection contributes to gastric cancer development. This is one of the most famous papers by Dr. Uemura in Japan. He traced over 1,500 people and prospectively investigated the occurrence of gastric cancer. This big data shows there is no gastric cancer occurred in H. pylori negative group, in contrast to 36 gastric cancer occurred in H. pylori positive group. So importantly, the occurrence is time-dependent manner. It's very important part. So the period after infection plays a cognitive role in developing the gastric cancer. Actually, the eradication of H. pylori reduces gastric cancer incidence. This is a narrative review of 7 meta-analyses on the regarding metachronous and primary gastric cancer incidence. The metachronous cancer incidence means that after eradication followed by ESD, please see the red panel. The relative risk or odds ratio was 0.4 to 0.67, and for the primary gastric cancer, the relative risk was 0.4 to 0.7. So, for the primary, this indicates that even if you treated cancer by ESD or EMR for H. pylori positive patient, eradication therapy is effective to prevent next cancer occurrence. Do you know how many cases are actually detected after eradication? So this is my experience. We retrospectively reviewed our endoscopy database and identified gastric cancer according to the H. pylori infection status. We reviewed 100,000 ESD reports, and I found only 8 to 90 cases for this database. So in the real world setting, we merely encounter gastric cancer after eradication. This is because it's very difficult to diagnose. So here is an example of gastric cancer found after H. pylori eradication. Can you diagnose or identify the region in this image? It's very difficult. I think it isn't so easy because there are lots of intestinal metaplasia by the reddish area. I will show you the answer later. These post-eradication cancers are difficult to diagnose, so they are frequently missed by endoscopists. This paper compared the characteristics of post-eradication cancer and H. pylori positive cancer. Please see the left panel. This is the eradication group and control group, 50 region each. So please see this size was 13.5 millimeter in size for eradication group, and the control group shows the 12 millimeter in size. This is not that different. However, the rate or previous endoscopy examination was much higher in the endoscopy group. It means these cancers were frequently missed. Please see the right panel. This is a typical case of gastric cancer found after eradication. This is the region, okay? This is just a scar. This region shows like a gastritis appearance, Why does not post-eradication cancer show such a gross appearance? Gastric cancer generated in the post-eradication because sometimes is covering normal foveal epithelium. We see this specimen stained by HE. You can see the deeper submucosal layer is tumor duct, but on the surface is the covering normal foveal epithelium with intestinal metaplasia. This finding is called as raw gastritis-like appearance, GLA. This table shows the eradication group has a significantly higher GLA appearance as 44%. In contrast, for control group, there is few population of GLA appearance. Then how do we recognize such a difficult to diagnose region? This is my answer to use image enhanced endoscopy IED. First, I'd like to introduce rate color imaging, LCI. This is a principle of LCI. The first capturing the image data and the processing it to enhance the color difference, so that the whitish color become more whiter and reddish color become more redder. So as a result, the increased color contrast supports a more accurate identification as well as the lesion and the inflammation. The next lesion is here. It's very difficult to recognize. Can you detect the lesion in this picture? This is a whiter image, and after changing to LCI mode, we can find the lesion here. Okay, this slightly whitish and elevated lesion appears in this area. You can see it here. In quarter image, the region is very obscure. This is the other case. This is the region. And the LCI can visualize the region as an orange color region, like this. This orange color is very important, key message to be noticed as a gastric cancer. This is the largest Japanese trial to verify the LCI for region detection, as Dr. Gotoda said. More than 1,500 patients with previous or current GI cancer were randomized to Wi-Fi image group and LCI group. As a result, LCI identified more cancers like this, so risk ratio was 1.67. So I believe that LCI is powerful tool for daily screening. The next modality is blue light method, BLI. BLI composes two parts of the laser. One is the short wavelength light. This blue light reflects the surface structure and effectively captures vessels on the surface of the mucosa. And the white light reflects the more deeper layer blood vessel and structure. So combining these two laser image, we can get this very clear image and visualize this vessel and structure like this. This is the typical mirror image. So do you know VS classification for NBI? By using magnified BLI, we can recognize microsurface pattern, and microvascular pattern like this. VS classification categorizes three types of the region: regular, irregular, and absent. Regular means the regular arrangement of microsurface or vascular pattern. But the cancer shows irregular or absent pattern like this. And importantly, we have to notice the border of the region. The border is called as the demarcation line. So if you can see demarcation line with irregular or absent microsurface and microvascular pattern, this region should be highly suggestive of gastric cancer. So magnified BLI is very useful to differentiate cancer and non-cancer. Please see the left panel. This is very excellent data to retrospectively compare by magnified BLI findings with the gold standard of pathological diagnosis. The sensitivity of magnified BLI was 93%, and the specificity was also 91%. Excellent data. So please try to use this modality if you find any suspicious region during routine screening. So here is the photo I presented earlier. By using LCI, we can recognize the vision here. The image was slightly rotated, so this vision is corresponding to here. Can you see the region? Importantly, we have to note this region as an orange color region by LCI. Then I changed the mode to VAY, magnified VAY mode. So can you draw the demarcation line? This is the region. But please see, this is not a demarcation line. This is just a border of information or indeterminate aperture. This is not the region. The border is here. Okay. So this is a demarcation line. In the demarcation line, we can find the irregular microsurface and vascular pattern. So we can diagnose this lesion as a cancer or high-grade dysplasia. So let us show the video. So this is the sequence of screening, detecting, diagnose, and treatment of early gastric cancer. So first, I use a white light image with AI. So this AI function called cat eye. Cat eye effectively detects a lesion like this. This is a blue box indicated by AI. And then I change the mode to LCI. The LCI is also available for this cat eye system. And then change to the magnified VAR mode. And in this vision, we can see the slightly disturbed vessel and surface pattern. And next, I perform the ESD for this vision. This is very tiny vision, so the marking is very limited to small area, like this. And then injected to the normal saline under the vision and cut with a tip knife, like this. The lesion was circumferentially cut it, and then I performed the submucosal dissection like this. You can see the blood vessel and sometimes coagulated vessels. Okay. And if we encounter the vessel like this, so please use an injection with a tip knife and make a distance from this vessel and cut it. And this is very small, so the whole procedure time was only 90 minutes. Okay. So the final diagnosis of pathology here. So please see this specimen. The red line indicates the cancer region. The cancer region is only limited to 2 millimeter size. This red line is perfectly corresponded to the region I pointed out before. And please see this histological assessment. Tumor duct is limited in the deeper layer of the submucosa, and the non-tumor duct was covered on the surface of the region with the indeterminate pressure. This is the typical finding of GLA, gastritis-like appearance. So the final topic is here. To reduce missed cancer using the latest technology by using digital technology. So this is my real experience. This patient underwent screening ESD 4 years after eradication. I performed this ESD. There is no lesion here. But just 1 year later, I can find this lesion here. Posterior wall on the lower body. I am so surprised, so I reviewed this lesion but I cannot find any lesion here. I think this is a perceptual or exposure error. So I think appropriate screening is equal to eliminating blind spots. So the next video using the modern technology. So please see the right lower corner. This is a function of landmark checker produced by Bushfield. The 7 parts of landmark is set in advance according to the anatomical site of the stomach, fundus, and greater curvature, lesser curvature, and angle, and pillows. And this video shows the function of landmark checker. Once we can capture the area indicated by this anatomical site, the area turns green. So I successfully take a picture of pillows. The area turns green. Okay. And lesser curvature also turns green. And just this area and fundus. So using this technique, it contributes to the reducing the missed cancer. And next function is cat eye. This is computer eye detection. This function is available for the white light image at ACI. So this is just a xanthoma, and this is not in cancer. This reddish area is information, and this is a cancer. Okay, indicated by a blue box. This is just a xanthoma. This is cancer, and ACI is also available. And then I changed the mode to the VAR magnification, and the detail of the patient is here. The slightly disturbed surface pattern and lesser pattern can be seen. So I can diagnose this lesion as a cancer. Okay, so this is the final slide of my talk. The incidence of gastric cancer after H5 eradication is relatively low. However, it sometimes possesses malignant potential. ACI is an easy-to-use modality and can find obscure lesions in post-eradication patients. And BLI can predict whether the lesion is cancer or not. And landmark checker and cat eye support to reduce missed cancer. So please use it. Thank you for your time.